Okay, let's unpack this. Today, we're diving deep into a malignancy that, well, it represents a genuine crisis in breast cancer management. This is really for those of you working in oncology, radiology, and pathology. We're talking about a subtype that seems to have, favorable biomarkers, the stuff we use every day to predict survival, but it carries this stubbornly high fatality rate that really hasn't budged in decades.
That is the absolute core of the contradiction we're exploring today. And this deep dive, it's built on a pretty incredible foundation clinical, imaging, and long-term outcome observations spanning over 40 years.
40 years, that's a huge data set.
It's from Dalarna County, Sweden. It gives us the kind of longitudinal data that, frankly, we just rarely get to see.
So our mission is centered on this critical paradox. How can a cancer that looks good on paper low proliferation, hormone receptor positive, how can it be so lethal? We're going to highlight how this particular entity, which is conventionally called diffusely infiltrating lobular carcinoma, just defies standard diagnostic imaging. It undermines our predictive IHC, and it resists our best contemporary therapies.
And the numbers, they really bear out that urgency. This subtype completely challenges the whole diagnostic and therapeutic framework we've built.
So what are we talking about, survival-wise?
Well, its profile might suggest a great outcome, but the actual long-term data, we're talking 20-year data, shows only an approximate 60% survival rate.
60%. That's shockingly low for something that looks favorable.
It is. And if you compare that to the prediction you'd make based on its markers, it becomes so clear that we are fundamentally misunderstanding its underlying biology.
Okay, so let's start with a practical challenge. For the clinician, for the radiologist in the room, when most breast cancers present with a focal mass, why is this one so consistently found late, and what are the clinical signs that should be setting off alarm bells?
Clinically, it's almost defined by its lack of definition. It avoids all the classic presentations.
No lump.
You don't get that discrete, palpable mass or the focal skin retraction that makes detection, relatively easy. Instead, the initial physical finding is just this indistinct, often diffuse regional thickening.
A thickening.
But the truly pathognomonic clinical sign, the one that really should be taken extremely seriously, is progressive, measurable shrinkage of the affected breast.
Breast shrinkage. That is so counterintuitive. I mean, malignancy is uncontrolled growth, right? Why would it shrink?
It shrinks because the cancer cells themselves, they aren't forming a big tumor ball that pushes tissue out.
Okay.
Instead, they are inciting this enormous desmoplastic reaction. It's a massive proliferation of fibrous connective tissue, or stroma, that actually contracts.
So it's the scar tissue of the stroma that's pulling everything in.
Exactly. It's the connective tissue pulling the breast in on itself, not a mass pushing outwards. And that contracting effect, by the way, is why breast MRI often captures that overall reduction in volume much better than other modalities.
So what about on the mammogram? In this contracting field, what are we actually looking for?
The dominant mammographic feature is extensive architectural distortion. It's often described as haphazard or sort of spider's web-like.
Right, I've heard that term.
And that distortion is the direct imaging counterpart of that massive fibrous tissue proliferation. And crucially, this cancer plays dirty. It omits a key early warning signal. It generally lacks the malignant type microcalcifications that we rely on so heavily for the early detection of, roughly a third of the more common ductal origin cancers.
So the radiologist is looking for architectural distortion, but without the safety net of calcifications. Let's talk about shape, because you mentioned this is a critical geometric distinction.
This is where we see the fundamental difference in how it interacts with the breast tissue. The more common ductal origin cancers, they form convex contours.
Meaning they bulge outwards.
Yes, they're spherical or lobulated or stellate. They physically protrude, pushing the surrounding adipose tissue outward. They stand out against the fat.
They're pretty easy to spot as something foreign.
Exactly. They are space-occupying lesions. But this diffusely infiltrating subtype, it forms concave contours with the surrounding fat and connective tissue.
So it pulls inward, creating dips instead of bumps.
Precisely. It doesn't push, it pulls. It infiltrates in these thin strands along existing structures, and in doing so, it mimics the appearance of normal fibroglandular tissue.
Which is how it hides.
And becomes very extensive before a definite diagnosis is even possible. And that's also why handheld ultrasound, which is great at visualizing the density and thickness of that fibrous tissue, is often more sensitive than mammography.
Okay, so if the imaging is this misleading, Let's move to the microscope, because this is where the authors suggest we need a complete reclassification. They argue the conventional name is wrong.
Yes, they say classic infiltrating lobular carcinoma is misleading and propose something new. Breast cancer of mesenchymal origin, or BCMO.
BCMO. That's a major conceptual leap for breast oncology, isn't it?
It is. It forces us to stop focusing only on the epithelial component, the ductal or lobular cells, and shift our attention to the tumor's command over the stromal environment. That extensive distortion we see on the images is the signature of this.
Reflecting the pathology.
Exactly. It reflects that underlying excessive proliferation of the supporting mesenchymal tissue, the fibrous stroma.
But pathologists face a major hurdle in seeing this, don't they? I mean, traditional biopsy and standard sectioning can actually hide the true extent of the disease.
They absolutely do. When we use traditional small section histopathology, taking these little fragments, the structural contiguity is just lost.
You lose the big picture.
You can't perceive the full extent of this massive contracting fibrosis. And that directly contributes to the challenges of surgical margin assessment and, well, overall management.
So what's the solution they propose?
The source material strongly advocates for using large format, thick section histopathology. We're talking about subgroup slides, maybe 12 by 9 centimeters.
And for those unfamiliar, that's not just a matter of using a bigger slide, is it? It's a whole different process.
No, it's a complete change in workflow. Preparing and reading 12 by 9 centimeter slides is technically demanding, it's time consuming, it needs specialized equipment, and it increases cost.
But the argument is it's worth it.
The argument is if we can't visualize the true extent of this desmoplastic reaction, we will just keep underestimating the disease. These large sections are vital.
Okay, let's get down to the cellular level. E-cadherin negativity. This is the crucial IHC finding that supports this whole BCMO theory. Can you break down why this staining pattern argues against the traditional origin story?
Sure, so E-cadherin is an adhesion molecule. It's basically the glue that holds epithelial cells together.
Right.
And it stains positive in normal epithelial cells and in the common AAB cancers. Crucially, the neoplastic cells of this diffuse BCMO are consistently E-cadherin negative. They've lost that cell-to-cell adhesion.
Or unstained, so they lose their cohesive structure.
Precisely. This loss of E-cadherin is what allows the cells to infiltrate in those single-file strands instead of sticking together to form a mass. It's a critical discriminator.
And what does that tell us about where it comes from?
Well, you often find these malignant E-cadherin negative cells surrounding acini and ducts that still have normal E-cadherin positive epithelial cells inside them. That relationship, it argues forcefully against the TDLUs being the site of origin for this specific, highly aggressive entity.
And to connect this to the bigger picture in oncology, the authors draw a really powerful parallel to a cancer in a completely different organ.
Yes, they link BCMO to hereditary diffuse gastric cancer, often known clinically as linitis plastica.
The leather bottle stomach.
Yeah, the very same. That's where the stomach wall becomes thickened and rigid. And that disease is also linked to mutations in the CDH1 gene, which, is the gene that codes for E-cadherin.
So what's the common denominator here between a shrinking breast and a leather bottle stomach?
The striking common feature is that massive, unchecked overproduction of fibrous connective tissue in both organs.
The stromal reaction.
It suggests the aggressive mechanism is deeply rooted in that fibrous stroma response, the mesenchymal component. And the E-cadherin loss is what seems to initiate that devastating pro-fibrotic cascade, whether the cells are in the breast or the stomach lining.
So the lethality is driven by the structure it creates, not just the cells themselves.
That's the paradigm shift.
Which leads us directly to the most frustrating part of the study, the prognostic failure and the therapeutic resistance. If we're targeting epithelial markers, but the lethal driver is mesenchymal, well, it explains why our standard toolkit has been so ineffective.
It explains the therapeutic tragedy. Again, we are dealing with a population where the approximate 60% long-term survival over 20 years is just unacceptably low.
And it's so low despite a molecular profile that looks great.
Exactly. That's where the deception lies. BCMO is overwhelmingly ERPR positive and HER2 negative.
And a low proliferation index, right?
Almost always. The Ki-67 is often less than 5%, rarely above 24%.
And for almost any other breast cancer subtype, those biomarkers would predict a great outcome.
A very good long-term outcome. For a small AAB, you're talking survival rates of 84% or higher. But for BCMO, those favorable biomarkers are profoundly deceptive. They're unreliable.
It doesn't matter if the Ki-67 is 5% or 24%.
It doesn't seem to. The cancer still behaves aggressively because its lethality is governed by the structural component, not the proliferative rate of the epithelial cells.
And the data confirms this failure. 4 decades of observation and the survival curves have barely moved.
Which really raises an important question for everyone listening. Are we simply applying the wrong solution to the wrong problem?
Tell us about the intervention data.
The long-term survival has shown no significant improvement between, say, 1977 to 1984 and the more modern era of 1995 to 2004. Postoperative radiation, for example, didn't appear to significantly change the 20-year survival course.
In chemotherapy.
Similarly, chemotherapy usage was associated with a 20-year survival of about 57% compared to 66% for those who didn't receive it.
Wait, hold on. If the survival was actually lower in the chemo arm, that just underscores the ineffectiveness of our current agents against this specific entity.
It does. It demonstrates this fundamental lack of success using regimens designed to target the epithelial cell cycle or hormonal signaling. And while standard prognostic indicators like lymph node involvement and LVI still negatively impact the outcome,
These still matter.
they do, but the source material makes a crucial point. Even node-negative and LVI-negative BCMO cases still carry a significantly worse prognosis than other subtypes. The problem is the inherent biology of BCMO itself.
So we circle back to the one factor that is proven to be an honest prognostic indicator. It's not the Ki-67, it's not the ER status.
No. The most reliable prognostic indicator we have for BCMO is radiological. It is the imaging biomarker of extensive architectural distortion and the associated breast shrinkage.
The physical manifestation.
That physical manifestation of the massive fibrous proliferation. That remains the one reliable predictor of this specific poor long-term outcome, and it overrides all that deceptively favorable IHC.
This has been a truly vital deep dive, especially for anyone on a multidisciplinary breast tumor board.
Yeah.
So to quickly summarize for our listeners, we're talking about a breast cancer subtype that really should be recognized as breast cancer of mesenchymal origin. It's insidious, clinically presenting as thickening and shrinkage, and radiologically, it's that spider's web-like distortion with concave contours, often without calcifications.
And critically, its low Ki-67 and favorable hormone status are misleading, betraying a high fatality rate. The long-term data shows our current therapies, designed for epithelial targets, have failed to improve that dire 60% long-term survival.
The urgent call to action for the medical community seems clear. Radiologists have to be hyper-vigilant for these subtle contracting signs. And pathologists, well, they need to push for integrating techniques like large section histopathology to truly see the extent of this fibrosis.
Absolutely. And finally, a provocative thought for you to carry forward as you think about therapeutic strategies for this. Given that the aggression of this breast cancer of mesenchymal origin seems so fundamentally rooted in the structure, in the excessive fibrous stroma, rather than just the epithelial cells, how can we develop truly innovative, tailored therapeutic regimens that focus not on the standard markers like ER, PR, HER2, Ki-67, which have proven irrelevant, but instead target the tumor's mesenchymal connective tissue component? Should the future of treatment for BCMO involve breaking down the leather bottle rather than just trying to kill the cells inside it?